That's a good point, but I don't mean that way.
Is that when your blood pressure comes it's not measuring because of the dissection?
No.
When you put on like one place where it differs versus another place?
Yeah, you are putting the cuff here, but this is the arm that gets affected, is under, is involved in dissection. So it's ischemic. You will have blood pressure of 80/50, and you think the patient is in shock, but actually the patient is esmolol, because if you check other place, other side, it's 210/8. This is pseudo hypotension. So just a number from one cuff doesn't mean anything. The same as A-line. When you're placing an A-line, make sure you place it in somewhere that is not affected by the dissection itself. Make sense? Second point, after presentation. So we justified some of those. Why think about it more? You should have more negative CTs because of those 66% and 28%. Just when it's not ACS, we discussed it. Why? Because coronary arteries might be involved, and then you will have a STEMI, even an EKG. Obvious STEMI and EKG and troponin, but it's still dissection. And we discussed why you should consider all these at even no pain, and go ahead and think about it and order CT. And we also discussed why you should be quick, because it kills quickly. Okay? So basically we kind of covered everything, but let's go ahead and do a little bit more dig into it. Time, I guess. Good. Good. 5 to 10? No, 10, please. So, what do you order? What do you order? You order CTA. Everybody orders CTA, right? Let's see. You don't order D-dimer? Nobody considers D-dimer? It's a huge talk about D-dimer in dissection. And we actually had that discussion with Brian and Eden in the email set that we were preparing this, and we never agreed. So we are not going to agree. It's being said that sensitivity is up to 100%. Some systemic review methodologists say that specificity is lower. So it's being said that you can use this for ruling out in a low-risk patient with negative likelihood ratio of 0.079, which is pretty good, less than 0.1. But it's also questioned that the studies that went into the systemic review and meta-analysis and gave us these numbers are not prospective studies, not controlled studies. They are bad studies, so the numbers are not really that much trustable. And there are reports that you can miss up to 18% of dissection with D-dimer. If you're using D-dimer, it's going to be high in the first hour more than anything else. And there are some recommendations. I don't want to go through them or the controversy. So I would say not ready yet. Maybe, maybe not. Not at this point. What about troponin? Not only it's not helpful, but it's actually harmful because it might be misleading. So useless. What about EKG? It's not a great thing to diagnose. It's good to detect right coronary artery, but interestingly, you can have MI on the left side, on LAD, on all other distributions from this dissection. So right side or not right side doesn't mean much. So basically it's useless. Chest X-ray. Why do you get some negative literature? 0.3, you might have some effusion. It's a good thing to do a chest X-ray and to see if you find anything. There are cases, a lot of cases, that this first suspicious started from the chest X-ray, like this. What do you see on this? A huge, large mediastinum, right? This is the aorta all the way down. Good? Or this one, the same thing, right? When you see something like this, you would think more about dissection. But it's missed in 28% of the dissection. Chest X-ray is negative, so cannot rule out. So better than the two before, but still useless, right? And what about this? What is it? This is a bedside echo. What do you see on it?
Flapping.
This is what you see. This flap that goes back and forth is the dissection. This is the aortic base. Or you can, if it goes all the way down to abdomen, you can see it from here. As you can see, there's a flap there. How good is bedside ultrasound in detecting dissection? I know at least 2 of our residents, Paul and Adam, that diagnosed a dissection with bedside ultrasound. So it's good, at least from our own residents. But it says, this is not very sensitive, not very specific, and cannot rule out really, but it is helpful. Actually, recommendation grade 1C to do the first thing that you do at bedside is bedside ultrasound. So do it. It's not going to rule out, but you might find something that makes everything happen faster.
I think a good takeaway point is to also do the belly ultrasound.
Yeah.
So like if you're thinking
Great.
dissection, you gotta look at the belly. Almost all the case reports and stuff for bedside ultrasound diagnosing a dissection are the belly.
Also, look at this view. This is a new view to me. I've never used it. I should get more, used to it. This is suprasternal view. Look at it. You can see the aortic arch. That's the aortic. That's normal, and this is what you would see if there's a dissection. And there's a dissection flap here. I should try this more. It adds to your sensitivity.
It should be the other way, actually.
Yeah.
They're pointed down.
Yeah.
Which is
Okay.
a very dissection. This would be very acute.
I see.
Pointed down.
I see. Yeah, you're right. This picture, I don't know why they put it like that. Okay. So what about TEE, transesophageal echo? It's actually pretty good. It's still not as much as CTA, but it's good. It's actually recommended to get it especially if the patient is unstable, it's recommendation 1C, because you cannot take the patient to CT or MRI. So if you can get ultrasound echo from inside at bedside, would be great. Sometimes it happens. I've seen that. Most of the time it doesn't, but it's good to know. And then this, how good is CTA? It's great. It's not 100%, it's like 98, 99 sensitivity and specificity, but it's great. So basically, this is the level of recommendation for CTA versus MRI or TE. You all know what's the problem with MRI, although it's recommendation 1C for diagnosis. You all know what's the problem with TEE, that how much we cannot get it done. But CTA is the way to go, right?
You should point out if you really do dissection that chest, abdomen, and pelvis, not just chest, because you see CTA, you might.
Very good point. That was done on our patient as well. It used to be angiography as gold standard, which is out. It's not sensitive, not specific, but this was interesting that this is recommendation level 1C. If you see negative imaging, you still think of CT dissection, you need to repeat it. Even more CTs. I'm so sorry. What about unenhanced CT? If you don't want to give the patient contrast, maybe patient has some kidney issues, although contrast nephropathy doesn't exist, so I don't want to get into that battle. So if the patient has contrast allergy, it has a good sensitivity for first step. If you can't give contrast, just do it. You might get something, right? 94% sensitive. So now the treatment. What should I do? Tell me. What do you give? Beta blockers. That's. First of all, be fast. Control blood pressure and heart rate. These are the goals. Blood pressure 100 to 120, and heart rate below 60. These are the goals. Why? You just want to less push on that hematoma that is inside the wall, right? And control the pain, because the pain itself can bring the blood pressure up, and then cause surgeries. This is basically what you need to do, as quick as possible. Start with the beta blocker, but there's almost no evidence that tells us beta blocker is better than cardiac calcium blockers or vasodilators or anything else. There's no comparison between these. And there's also no comparison between different beta blockers. There's almost nothing. So it's just all anecdotal that we give beta blocker. Usually it's recommended to start with desmolol because beta 1, because it's more controllable, more drip, you can more predictable, and short half-life, you can stop it if it goes too down. And then labetalol is usually recommended the second place because it's less titratable, more stays there a little bit more. But I think labetalol especially is very good because, setting up a drip for esmolol is hard. When you want to give something right now before the patient goes to CAT scan, labetalol might work better. Just to give push, 10 minutes, twice as much push, and go ahead until you control the blood pressure, or you get the esmolol drip down, right? There's also saying that you can consider metoprolol, propranolol, you can consider it anything you want. But just bring the blood pressure down. After beta blocker, if it doesn't work, or for some reason you don't want to give beta blocker, I don't know how much you want, for asthma, you had a history of asthma, you don't want to give beta blocker, but the patient is dissecting is important, but it's in the literature. You can consider nicardipine that you use for everything else, like hypertensive emergencies, and it's a very good drug for this as well. You can just add it. If you are used to nicardipine, it's a very good thing. Or other calcium channel blockers or vasodilators. Nitroprusside also recommended in different sources, although it gives you tachycardia, reflex tachycardia, so only use it after you started beta blocker to control the heart rate itself. Some people say they start with nicardipine, some say nitroprusside. There's no evidence behind any of those. It depends on you. Also other drugs. And if it's cocaine, benzo probably brings down the blood pressure more than anything else. And then surgery, call for all of them immediately. All type A and type B for any complication, end organ ischemia, anything like that, you need surgery. And surgery actually is pretty helpful. Survival with surgical management, immediate surgical management is 92% versus dying 50% at day 2 without surgery. It's so pretty amazing. And hospital 14% compared to 67% without surgery. So it's impressive. For type B, that doesn't include ascending aorta, there's not much difference in the control trial between the medical management, meaning just controlling blood pressure and letting it go and just monitoring over time, versus doing surgery. Although for endovascular repair, it's a little bit promising, and it looks like it's better than medical management alone for even type B. And this is actually what our patient is going to get probably this week. Okay? And then if it's chronic, this is the mortality rate. 5-year mortality is 50%. Chronic type B, I mean, specifically, because type A, you will do surgery for sure. And you need to do follow serially, surgery if necessary, anything like that. And finally, what would you do if the patient is shocked? Make sure it's not pseudo-hypotension. You have blood pressure all over the place, and it's low. The patient is hypotensive. What would you do? There is not much evidence on this, really, really scarce. But it makes sense to take the blood pressure up a little bit to the point that tissue perfusion is okay so that you can take the patient to OR. That just makes sense. No evidence behind it. So you can start with some fluid, you can start some pressors, and if you think low blood pressure is because of tamponade, you might consider doing precardiocentesis and taking a little bit of blood out from the pericardium to give a little bit better push. Although some say this is actually harmful. Some say, what if the patient is going to die right now and needs to go to OR, and I just want to get them to OR, just 10 cc. So it's maybe, maybe not. But if the patient is going to die in front of me, I would probably do it. Second point, think about it. You should have many negative CTs. Chest pain is not ACS, even with positive troponin. You should rule out dissection as well. Any pain with neurodeficit, with pulse deficit, with moving to the belly, back, having any of those risk factors, Marfan, any of those. Something on the chest x-ray or murmur, think about it. And finally, be quick, echo, CT, call surgery, control blood pressure. That's it. These are my references. Questions?
So last, while I respect your comments on getting more CTs, that's on dissection. But I think if you, as you mentioned in your last slide, if you do a really good physical exam, you can really increase the yield of CT. And the one likelihood ratio that you didn't mention, which is important, is any complaint of neurodeficit in the history or finding a neurodeficit, the likelihood ratio for positive test is 33. So it's significantly, it's the only thing in physical exam and history that has a meaningful helpful likelihood ratio is the neurodeficit.
For a patient with chest pain?
With chest pain.
Okay. I haven't
So
seen
if
that.
if you have a patient with chest pain and the patient complains of any neuro issues, vague numbness in their toes or any weakness, that should turn a light bulb in your head that let's make sure this is not dissection.
So patients have that?
I'm sorry?
What percentage of patients have that?
I don't know, but because the likelihood ratio in negative test is not that great, I don't believe that a lot of patients have that. So if you don't have it, the likelihood ratio is not that great. It doesn't rule out the dissection. But if you have it, if you find it in a patient with chest pain, it significantly increases your predisposed probability, gives you a good prognosis probability.
Score-wise, there would be a score of 2, which is high probability as well. Yeah. Anything else?
So with individuals with really high pretest probabilities, for instance, this case, I think it was clear that everyone was likely to do.
If you just have chest pain, you just score was 1. But yeah,
But
clinically
up,
gestalt,
going
yes.
to the back, going
Yeah.
down to the
Yeah.
belly, very hypersensitive. Anyway, what point do we really begin to be very aggressive with the blood pressure control? Empirically, are you starting your nerves right away before getting the CT? Does that give any benefit?
I've never seen anyone talking about it in the papers, but I saw some recommendation, probably not evidence-based, that start with labetalol before CT. Give something to bring down the blood pressure before sending them to CT if you're thinking about it. Don't let them go to CT and be hypertensive there. That's what I can tell you.
One more comment and then we're going to wrap up.
So regarding the study that Dr. C quoted, so unfortunately that study is kind of discounted because it had likelihood ratios that were wildly inconsistent with the rest of the evidence. So there's one study that has a likelihood ratio of 33. There's one other study that looked at neurodeficits in dissection, and that likelihood ratio was 6.6, which is still the best likelihood ratio for any sort of physical exam. So I agree that neurodeficits is very important to consider, but the 33 I think is a little bit of a misleadingly high likelihood ratio. I think the only other thing that I want to mention was like for D-dimer, we had a nice discussion about this. So with a negative likelihood ratio of 0.079, that is incredible, right? You can really lower your post-test probability, but of course you have to select the patients very properly, right? So it's just like you're not indiscriminately using a D-dimer for PE. Anyone with any sort of even remote chance of like having a dissection, you probably shouldn't use in these patients. Also, they could be falsely low in patients with a short dissection, patients who are younger, and if they've already thrombosed off their dissection, which is kind of a protective mechanism that's body
Thank you.